Hey all, welcome back to the Real Life Pharmacology podcast. I'm your host, pharmacist Eric Christensen. Thank you so much for listening today. As always, go check out that Top 200 study guide, absolutely free. Simply an email will get you access. You can do that at reallifepharmacology.com. We also get you updates when we've got new podcasts and other content available as well. So again, go check that out. Free 31-page PDF study guide on the top 200 drugs at reallifepharmacology.com. All right, the drug of the day today is Piperacillin Tazobactam. That is a combination of two medications. Brand name you'll most commonly hear is Zosyn associated with this medication. This is an IV-only medication, so it's obviously primarily going to be used in an inpatient infusion type of setting in most situations, with some, occasional exceptions to that, of course. So again, we've got kind of a combination medication here. And as you could probably tell by the ending in piperacillin, this is a penicillin type antibiotic. It is what's considered an extended spectrum, and basically all that means is it covers a bunch of different bacteria. You may also hear it termed as a broad spectrum antibiotic as well. So mechanistically, piperacillin inhibits bacterial cell wall synthesis by binding to penicillin binding proteins. Now, the other component of this medication, Tazobactam, this irreversibly inhibits many beta-lactamases, which ultimately prevents piperacillin degradation by bacteria. So, what are beta-lactamases? These are enzymes that are actually produced by bacteria that can help the bacteria basically survive and help them destroy antibiotics that are looking to do them harm, which obviously we're trying to kill the bacteria in a patient having an infection. So beta-lactamases are an interesting way that bacteria have evolved and allows them to try to live and avoid breakdown by traditional antibiotics such as amoxicillin, for example. So again, the Tazobactam portion helps to inhibit these beta-lactamases, which obviously allows for the antibiotic piperacillin to better do its thing and ultimately help treat that infection and kill the bacteria. Indications. So again, being a broad-spectrum antibiotic, piperacillin Tazobactam can be used for a ton of different indications. Okay, so it's got gram-positive coverage. It's also got gram-negative coverage. Covers some anaerobes. Two of the most probably highly testable things that you're going to see in pharmacology classes and board exams. It does have activity against Pseudomonas aeruginosa, very common kind of drug-resistant type bacteria. It does not have coverage or activity against MRSA, so that's methicillin-resistant Staph aureus. Okay, so those are two important things to remember there in practice, as well as something that could come up on your exam as well. Indications, so we could use it for anything from intra-abdominal infections, skin and soft tissue infections, hospital-acquired pneumonia, for example, community-acquired pneumonia, even in rare cases, and in more serious type of infections, or maybe there's some resistance or a bug that our traditional agents don't cover. Gynecological infections, complicated gynecological infections, septicemia. So again, lots of different uses for this potential broad-spectrum antibiotics, and it's one of those antibiotics that's frequently used as what's called empiric therapy. So we don't know necessarily what's causing an infection. So we try to get an antibiotic initially on board quickly. That's hopefully going to cover that bacteria. And then ultimately we can potentially back off on using a broader spectrum antibiotic and transition to maybe more of a more targeted antibiotic for that specific bacteria, when we figure out in the coming hours and days when we figure out what's causing that bacterial infection. Dosage form, so IV only. Does have a relatively short half-life, so you're probably going to see every 8 hour dosing with this medication. Obviously, more severe infections, we're probably going to have higher dosages. Pay attention to renal function with this medication. We may have to alter some things, whether it be longer interval, lower dose, or a combination. That can certainly happen with this medication. So again, pay attention to renal function there. And again, like I alluded to, when dosing this medication, we often use it as empiric therapy for a lot of different infections. Adverse drug profile. You can probably correlate it with penicillin antibiotics in general. You can certainly have some GI issues, some diarrhea, nausea, that type of thing. Also could cause some rash, kind of rare, but maybe more serious things. Could contribute to, C. diff colitis, could have a hypersensitivity reaction. Nephrotoxicity, it has been associated with that a little bit. Primarily, it's going to be higher risk with a medication like vancomycin that's already can contribute to some renal issues there. And then, hepatotoxicity has been reported. Seizures have been reported as well. And neurotoxicity kind of associated with that. Generally for, the neurotoxicity, seizure risk things, some of the risk factors that may increase that risk. Obviously, renal dysfunction, the drug may be more likely to accumulate. If they have underlying prior CNS issues, history of seizures, older adults, critically ill, sick patients, and then at higher escalating dosages, we may increase that risk potentially for that neurotoxicity and an incident for a seizure, for example. Contraindications, warnings, precautions. Obviously, if somebody's got severe hypersensitivity to penicillin antibiotics or beta-lactamase inhibitors, that could be a good potential reason to avoid this medication. Seizure risk, I alluded to as a potential kind of precaution. If we don't have any other options, we may still use it and monitor, for example. Again, going to kind of want to look at that on a case-by-case basis and look at each individual patient there. And then, if you've got a patient that's, at risk for, fatal anaphylaxis due to reactions, those type of things, that might give you a little bit more caution there. At risk for C. diff, kind of one last precaution there, maybe a little bit as well. The kinetics, just want to touch on that briefly. Generally, like I said, very very short half-life in the range of an hour or two. Again, this can be altered a little bit if you have somebody with poor renal function. That half-life may go up, it may be a little bit longer than that. But important to remember that it's renally eliminated as far as the pharmacokinetics go. All right, let's take a quick break from our sponsor, and we'll wrap up with drug interactions. If you're in the market for any pharmacist board certification study material, like the pharmacotherapy exam, BCPS, ambulatory care, BCM-TMS, geriatrics, NAPLEX, go check out meded101.com/store. We've helped thousands of pharmacists pass their board exams, and we can absolutely help you too. So, again, go support the sponsor, meded101.com/store. Your purchases there go directly to support and fund this podcast. So greatly appreciate your support there. Also, if you're a nurse, med student, pharmacy technician, we've got books, we've got resources, we've got all sorts of different stuff depending upon what role you have in healthcare. And we try to create some medication-related content for all you folks as well. Available for purchase, Amazon books, things of that nature as well. So, again, all those links, meded101.com/store. All right, wrapping up with drug interactions. Don't need to worry about CYP enzymes really too much, so that's a nice thing with Zosyn. Probably the two biggest things in relation to Zosyn concentrations is in relation to medications that can kind of alter the renal function potentially and alter how much of that medication is kind of reabsorbed in the kidney. Probenecid, not a very commonly used medication, but definitely one that can work on the kidney and actually increase the concentrations, levels of Zosyn. So it ends up mechanistically blocking tubular secretion of the drug, and that drug actually stays in the body for a longer period of time. So probenecid can do that. Methotrexate's another one. I probably see a lot more methotrexate than probenecid, but methotrexate can actually kind of compete for renal clearance and increase concentrations of Zosyn. Other big thing I would say, I do pay attention with warfarin, which, again, when we're using IV Zosyn, this is probably a hospitalized patient or a patient under close care, and we're probably getting labs pretty frequently already. So if you've got a patient on warfarin, and they're sick, you're probably checking INR relatively frequently anyway, so you're going to catch that interaction. So, again, I don't have too much stress over it just because I know typically how closely somebody on Zosyn is going to be monitored. But if you got a rare situation where maybe they've started Zosyn, it's been 3, 4, or 5 days since we've checked an INR, probably a good time to double check that and make sure that we're not increasing the risk for bleed by increasing that anticoagulant type effect. One last one I'll mention, definitely not typically crazy serious, and again, we're probably going to be monitoring this. So there is some evidence that Zosyn can contribute to hypokalemia in patients taking diuretics. So let's say you got a patient on furosemide, for example. There is some potential that Zosyn could exacerbate that a little bit. Again, we're probably going to be checking renal function. We're probably going to be checking electrolytes on a fairly routine basis in somebody getting Zosyn, but it is something to think about that it could contribute to that a little bit as well. All right, well, I think that's going to wrap up the podcast for today. Do me a huge favor, support the sponsor, meded101.com/store. Also, if you have 30 seconds, go to the podcast platform of your choice, leave a rating, review on iTunes or wherever you're listening for the podcast. If you benefited from it, find it helpful, I'd greatly appreciate that. And of course, share us with friends, colleagues, pharmacy students, med students, nursing students, whoever's going through pharmacology classes. Please feel free to share the podcast with them. If you want to reach out to me, Eric Christensen, PharmD, BCPS, BCGP. You can find me on LinkedIn. You can also track me down at mededucation101@gmail.com. Thanks again. Appreciate you guys listening. Take care. Have a great rest of your day.